talk. Now it's my great pleasure to invite to the stage my dear friend, Dr. Sarah Al Ghamdi. Dr. Al Ghamdi is an assistant professor and consultant gastroenterologist and advanced therapeutic endoscopist at King Abdulaziz University. She has trained in the University of Toronto and Johns Hopkins Hospital. Thanks, Sarah.
Thank you for the introduction, and thank you to the organizing committee and the Kuwait GI Association for this very kind invitation. So today I'm going to be talking about management of pancreatic fluid collections, when and how to pop the bubble. So I have no disclosures. So these are my objectives. Skip over. So acute pancreatitis, we know, is the most common pancreatic disease worldwide, and it's actually the third leading cause of GI-related admissions in the US. And here you can see a figure from a meta-analysis systematic review of 44 studies, which shows that the increase of acute pancreatitis is actually increasing over time. Most of this is led by biliary pancreatitis. In our region, interestingly, the only data we have is from Qatar, where the incidence has actually been decreasing according to their studies. So still, we still need to do more research in this area. It's still relatively an untouched area. So acute pancreatitis we classify into two classifications: interstitial edematous pancreatitis and necrotizing pancreatitis. Of course, interstitial pancreatitis is much more common, occurs in 85% of acute pancreatitis cases. And this basically is due to inflammation, which damages pancreatic ducts and then leads to extravasation of pancreatic fluid. This can lead to acute peripancreatic fluid collections, and it has about a 2% mortality, so relatively low. Necrotizing pancreatitis, which is less common but more morbid, leads to intra or extra pancreatic necrosis collections, and mortality can reach up to 17%. So of these patients, who develops fluid collections? So with interstitial pancreatitis, about 30% of patients will develop an encapsulated fluid collection. It's usually well defined and usually extrapancreatic. And has minimal solid content or debris. So about 30% of these will progress to a pseudocyst, and that occurs usually 4 weeks or more after the episode of pancreatitis. With necrotizing pancreatitis, about 50% of patients will develop a collection, and here we call these collections walled-off necrosis rather than pseudocyst. They do have a well-defined wall, and they contain pancreatic necrotic tissue. And on imaging, we see a lot of debris, sometimes solid content. So overall, the mortality, as we mentioned, of walled-off necrosis is quite high. It can reach up to 17%, and even higher if this necrosis becomes infected. So with sterile walled-off necrosis, the mortality reaches 15%, and with infected walled-off necrosis, it can reach up to 40%. However, multiple studies have shown that mortality is lower in centers of expertise because management of these complex and very sick patients does require a multidisciplinary team. So we need GIs, both general and advanced endoscopists. We need surgeons on board, interventional radiology, ICU, infectious disease, and nutrition to help manage these patients altogether. So why does infected pancreatic necrosis occur? Usually due to translocation of gut bacteria. And again, it's a late complication. It occurs within 4 weeks in only 25% of patients, but usually later. And usually it's patients present with new onset fever or clinical decompensation, sometimes persistent organ failure. And on CT, we see air fluid levels within collections and sometimes solid debris. So our approach to pancreatic fluid collections depends on the patient. There's two extremes of patients. We have completely asymptomatic patients who have fluid collections, and then we have the sicker and more morbid patients who have infected walled-off necrosis. So for asymptomatic patients, if they have no or very minimal symptoms, historically, we used to treat these if the fluid collection is of a certain size, but more and more, we have come to see that these patients should be observed clinically. We follow up their imaging in about 3 to 6 months, sooner if symptoms develop, just to ensure that the collection resolves. And spontaneous resolution of pancreatic fluid collections does occur in about 70% of patients. So most will do fine if they're asymptomatic with no intervention. On the other spectrum, we have the very sick infected pancreatic necrosis patients. These patients need, again, a multidisciplinary team, sometimes ICU admission for management. Antimicrobial therapy should only be started on patients with culture-proven infection or if we highly suspect an infection. And of course, we give broad-spectrum IV antibiotics for them. The routine use of antifungal agents is actually not recommended as per guidelines, and antimicrobial prophylaxis to prevent infection in these patients is also not recommended. Feeding, of course, is always a very important area to address with any pancreatic disease patients, especially pancreatic necrosis. Currently, we recommend to initiate early feeding, enteral feeding, to decrease the risk of infected necrosis. And a trial of oral nutrition should be recommended immediately once the patient doesn't have any symptoms that precludes them from eating orally. Here we just have an algorithm just to help guide us with regards to feeding. You can see that we should address nutrition very early on, the first 24 to 72 hours. We recommend oral intake as early as possible. And feeding can reach up to requiring a PEG tube or a PEG-J tube, but these are very, very rare cases. So regarding PPI, it's a very it's always a question for patients admitted to hospital. But in this study, you can see that we do recommend discontinuing PPIs, and this has been found to reduce the number of endoscopic procedures required for resolution of walled-off pancreatic necrosis. Of course, people's practice currently does vary, so not everyone will recommend discontinuing PPIs, but the thought is once you have acidic content in the stomach, that can help resolve the pancreatic necrosis, especially in patients who've been drained already. So when do we drain these collections? We drain them if they're causing symptoms, such as severe abdominal pain, early satiety, nausea, vomiting, basically symptoms of gastric outlet obstruction, or jaundice if it's causing biliary obstruction, or in patients who have complications, such as evidence of infection, established gastric outlet obstruction, biliary obstruction, recurrent acute pancreatitis, or persistent organ failure. And how do we drain these collections? So we have 3 approaches: endoscopic, either transmural drainage, EUS guided, transpapillary drainage, which is less often performed, and then we have percutaneous drainage if endoscopy fails, or if in conjunction with endoscopic drainage. This does cause a risk of fistulas, however. And then finally, if all else fails, we sometimes proceed with surgery, either laparoscopic or open drainage, or video-assisted retroperitoneal debridement. So always important, number 1, before we approach a patient, before we start considering drainage, we have to review imaging with radiology. Because our intervention and our approach will depend on the extent of the collection, the location, and the number of collections, and whether or not they're communicating with each other. Another thing we look at is the maturity of the wall. Here on the left side, you can see a collection with no mature wall. But on the right side, the wall has matured. So it takes a few weeks for this wall to mature. Another important thing we have to rule out on imaging is the presence of a pseudoaneurysm, which can occur with pancreatitis, as we all know. And placing a stent within the pseudoaneurysm can cause very severe bleeding. So this is one thing we have to keep in mind as well. And then, of course, we have to check for any evidence of necrosis within the collection. Some collections contain only fluid, but others contain necrotic tissue and debris. Here you can see this was a 55-year-old with biliary pancreatitis. She had a very large collection, and you can see the collection reaches the paracolic gutters. In these cases, percutaneous drainage is needed in conjunction with endoscopic. So again, for percutaneous drainage, if we have no window endoscopically to drain the patient, or if the collection extends to the paracolic gutters, we do consider a percutaneous drain. How do we manage these drains? Very important. Eventually, we tend to upsize the drains. And then we have to frequently flush these drains with at least 250 cc's sterile water every 2 to 3 hours. So it's a very tedious process, but it's important that these drains be flushed frequently without aspirating the fluid afterwards. Okay? Here you can see a video of video-assisted retroperitoneal debridement, not frequently performed, but you can see they've accessed through a percutaneous drain site. And then they go basically within the collection, you can see here, and debride it internally. And if you can see in a distance, there's actually a stent in this patient. So endoscopic drainage failed, and they eventually proceeded with surgical. So this was after cleaning the collection. So they can do it. Surgeons can clean up these collections pretty quickly, whereas endoscopically we tend to require multiple procedures, and this was the outcome of that patient. So endoscopic drainage, of course, what we perform. So you have two approaches, either endoscopic transmural drainage, where we create a fistula between the collection and the lumen of the stomach usually. Historically, they used to perform transpapillary drainage as well for smaller cysts, or if they communicate with the pancreatic duct if you have no access from the stomach or the small bowel. So in the past, the go-to method for transmural drainage was actually plastic double pigtail stents, as you can see in this picture. And this is the Seldinger technique, which is used for vascular access as well. Basically, we use a plastic stent and place it over a guide wire through the collection using either an upper endoscope or EUS scope. So of course, this has a risk of leak, displacement, or perforation. More recently, the LAMS, or lumen opposing metal stent, or anastomotic stent, was developed. It's a device basically where two luminal structures in the body are drawn toward each other, and a conduit is formed in between them. It's a one-step device. It's exchange-free, and we use it with an EUS scope. So basically, we access the target lumen with the device-loaded catheter and deploy it into the collection. You can see here the stents come in all shapes and sizes. And this is just an example of deploying a stent. So here you can see this is the catheter that we use. Of course, it's performed under EUS guidance. We deploy the two flanges. There's a distal flange, and then there's a proximal flange. And it's shaped like a dumbbell, so it holds in place pretty well. Okay. So of course, I'm not going to get into details, but these stents do have complications. It's a high-risk procedure. Yeah, some of these complications include bleeding, stent migration, perforation, or buried stent. This study basically included patients with walled-off necrosis who underwent LAMS placement with or without double pigtail stents. And they found that adding a coaxial double pigtail stent within a LAMS significantly lowered the rate of adverse events and stent occlusion rate. However, more recent studies didn't confirm the similar results. So more recently, I don't know, we'll maybe discuss it later, but placing a double pigtail stent is not routine after a LAMS placement. Here you can see, this is a collection on the left image. Before and after drainage, and you can see the shape of the stent. So if you see this on a radiology image, then that's what it is. So for walled-off necrosis, sometimes we do need to perform necrosectomy, multiple sessions of necrosectomy, and we use multiple different devices for this, including snares, baskets, forceps, irrigation with either hydrogen peroxide or high flow water, and more recently a device called endorotor that debrides the necrotic content. Here we have a video of a patient who underwent multiple sessions of necrosectomy using multiple different approaches. So you can see that our devices are quite small, so these patients tend to, and sometimes with very large collections, they tend to require multiple sessions. I think this patient needed 7 sessions. I'm going to skip through it. Yeah. Here we can see this is the endorotor device. where it suctions as well as cuts and aspirates the necrotic tissue, which I think it's being adopted more and more in the US. One important diagnosis to always keep in mind in patients with necrotizing pancreatitis is disconnected pancreatic duct syndrome. So basically, this occurs when you have a large area of necrotic pancreas, at least 2 centimeters in size, and then you have some viable pancreatic tissue in the disconnected upstream pancreas. So the necrosis, basically, it causes a disconnect within the pancreatic duct. This leads to, you can see a total cutoff, either on ERCP or MRCP, more so on ERCP. And then which communicates with the collection. So it's very important in these patients to keep a double pigtail stent in place indefinitely, because otherwise their collection will continue to reaccumulate. So by indefinitely, we mean forever. So after removal of the LAMS, which we usually do within a few weeks, we replace it with a double pigtail stent and keep that in place. So how do we remove these stents? Of course, this is an ex vivo video, but you can see the shape of the stent. You can see how tense it is. It's actually a very strong stent. We usually do a CT in 2 to 3 weeks to reassess the collection. And then we remove the stent with an EGD scope within 4 weeks. Keeping it longer tends to increase the risk of bleeding, tends to increase the risk of buried stent. And again, always permanent double pigtail stent if the patient has disconnected duct. So if you're going in with a gastroscope and you see this double pigtail stent in a patient with history of pancreatitis, just before you remove it, confirm that they didn't have a disconnected duct, because otherwise it will be impossible to access again. This study from almost 2 decades ago, comparing endoscopy versus surgery for necrotizing pancreatitis. Basically, patients were randomized to a step-up approach using a drain and then VARD and then additional surgery versus open necrosectomy, so initially a primary laparotomy and additional surgery afterwards. They found that major complications and death was more frequent in patients with open necrosectomy, so a step-up approach was recommended. Here, regarding hydrogen peroxide, it's a chemical, basically, that debrides solid components. This was a retrospective study with about 200 patients, and they found that using it during endoscopic necrosectomy had a higher clinical success rate and a shorter time to resolution relative to standard necrosectomy. This landmark trial, called the Penguin trial, basically compared endoscopic transgastric versus surgical necrosectomy for infected necrotizing pancreatitis. And briefly, there was no significant difference in mortality, but the endoscopic step-up approach led to less multi-organ failure, shorter hospital stays, less fistulas, and less total costs. Here, again, this was a more recent study comparing endoscopy versus surgery for necrotizing pancreatitis. It was a single-center RCT in the US, and again, no mortality difference, but the endoscopy group tended to have better quality of life score at 3 months and a less mean total cost. So an endoscopic approach should be the preferred treatment strategy for patients with infected necrotizing pancreatitis, given the overall clinical, health-related, and economic advantages. And then finally, here we have a study comparing early versus standard endoscopically centered step-up interventions for necrotizing pancreatitis as well. Although an earlier approach had higher mortality and higher surgical interventions, there was no increased immediate adverse events, and there was significant improvement in organ failure in treating these patients earlier. So critically ill patients who cannot wait 4 weeks should be considered for earlier treatment. So in summary, when do we pop the bubble? Symptomatic patients only, never in asymptomatic patients, and of course in infected necrosis. And how do we approach this? Endoscopy is the preferred approach, sometimes in conjunction with percutaneous drainage, and these have been found to be more effective with less complications than surgery. Plastic stents or LAMS, usually more and more we're using LAMS. I haven't seen plastic stent used in quite a while now, but there are multiple sizes, multiple shapes of LAMS to be used currently. And of course, you have to manage the presence of disconnected pancreatic duct if present. So a multidisciplinary approach is key.